from UKPDS demonstrating that even in a clinical trial, watching carefully, randomized to different therapies, they all failed in this study. Whatever they gave, conventional versus intensive, over 11 years, sugar control got worse in all the groups because they were using medicines which are largely old-fashioned. Now, in spite of that, the ADA still recommends these old-fashioned medications. I don't get it. I don't agree with it. Most endocrinologists don't, but it's information that is out there. We think we can do better than this. So if I can back up here. So what we'd like to do in 2012 is preserve beta cell function with the medicines that we use and your lifestyle changes without weight gain or with weight loss, without hypoglycemia, because we don't really want to make your blood sugar too low, and durability of effect. We want this to last as long as possible to avoid this gradual rise in glucose, this gradual failure of beta cell function. So we have, yeah.
Which are the old medicines that they still are recommending even though you find them to be not
Okay,
very
well, so
effective?
in this study, the patients were randomized to metformin, or to glyburide, or to insulin. But the way they did the insulin was a little peculiar. So those are the medicines that demonstrated no durability of effect over time. Okay? If you look at what I see, what comes in the hospital, nearly everybody on oral agents is still on sulfonylurea. Why? I don't know why. I do know why, actually. I just wish I didn't know why. Two reasons. Habit, they've been around forever, we know what they do, and cost. They're dirt cheap. So the sulfonylureas are a $4 prescription from Target or Walmart. The new drugs are $150 from Target or Walmart. It's a big difference in cost. But there may be a big difference in benefit, and that's what these clinical trials that are about to start are going to try to evaluate. We know from a trial called the ADOPT trial, if you randomize patients to metformin or to Actos or Avandia, it was Avandia in that trial, or to a sulfonylurea, that the sulfonylurea, glyburide in that trial, failed in 18 months. Metformin failed at 3 years, and the TZD, the Avandia, was still working at 5 years. A very clear separation in terms of protection of the beta cell from further failure. Now, Avandia got pulled off the market because concerns about cardiovascular safety. Actos is now in limbo because people are worried about bladder cancer, which may or may not be right, but they're still worried about it. So we have this, all medicines have their own issues, but we know that sulfonylureas exhaust the beta cell. They wear it out, and the beta cell gives up sooner. They do lower the blood sugar while you take them, but they don't last that long. At the hospital end, where I see them, they end up with hypoglycemia and sit here in the ICU on a glucose drip for 2 or 3 days because in older folks, they don't get cleared, they stick around, and they really have bad issues in terms of both low blood sugar and wearing out the beta cell. So, we know that diabetes is bad to the heart, it's bad for the kidneys, it's bad to the eyes, and it's bad for neuropathy. These are the things that we talked about, and leads to these issues of amputation. But when we deal with blood sugar, we have to deal with two basic questions. We want your blood sugar to be down here, in the light blue normal. Light blue normal, your fasting blood sugar, actually this is kind of old because it really should be lower than this, should be less than 100. And then after a meal, shouldn't go up above 160 or so, be back down less than 140 at 2 hours. So you get these little bitty wiggles in the baseline, but that's it. Fasting blood sugar is a significant portion of diabetes. Your blood sugar when you wake up in the morning is too high. And then every time you consume a meal, it goes up higher. This lump here is bigger than this lump for 2 reasons. 1, you don't clear it as well. And 2, your liver is still making glucose even though you don't need any more glucose because you just ate some. So it's lack of clearance, insulin not working very well, and overproduction by the liver of glucose at the same time. So when we deal with controlling blood sugar, we have two issues. One, get the fasting blood sugar down, get the post-meal blood sugar rise to decrease. All medicines for diabetes target one or the other. So no one medicine is likely to fix all parts of this abnormality, which is why most people are on more than one drug. Because you need something to lower the fasting blood sugar, you need something to deal with this rise after meals. So, how do we diagnose diabetes? Fasting blood sugar, I said, here's the current criteria. Greater than 126 is diabetes, 2-hour postprandial blood sugar, greater than 200, or hemoglobin A1C of 6.5. What are our targets for treatment? Targets are over here for ADA. Fasting glucose should be less than, well, that's the old target, I'm sorry. The current target is a fasting blood sugar of less than 100, postprandial blood sugar less than 180, and an A1C of less than 7. Normal A1C is 6, or 5.9. Why do we target a level that's not normal? Think about that. We want your cholesterol to be normal. We want your blood pressure to be normal. We want your blood sugar to be not so bad. Why is that? Because the downside of hypoglycemia restrains us from pushing the medicine too hard. But in 2012, we have several medicines that lower blood sugar with almost zero risk of hypoglycemia. And that's where we should be targeting our therapies, assuming we can persuade insurance to pay for the appropriate therapies. So metformin, DPP-4 blockers, GLP-1 agonists, TZDs, none of these cause hypoglycemia. And the triple combination of these medications will keep many, many patients off insulin. Not all. If you come to see me, I should tell you, you're very likely to see insulin. Well, because I get the people who didn't respond to this stuff before. So I'm not saying that my practice is representative of the entire population of type 2 diabetes. I see the folks that other folks have trouble managing. So these are the goals I showed you before. So to get diabetes under control requires more than just a physician. So I'm up here at the top, endocrinologist, diabetologist. Dr. Green's over in the right-hand corner. I saw these numbers at a diabetes meeting in Dallas over the weekend. There are, on the average, 4,700 patients with diabetes in this country for every single endocrinologist. That's more hours than I have in my day. So I take care of, last time I counted, about 2,000 patients. That seems like my patient population, and that's a lot, and they don't all have diabetes. That left 2,700 people that somebody else has to take care of, not me. And so most patients with type 2 diabetes are not managed by endocrinologists. They're managed by primary care doctors. And that's perfectly appropriate as long as they have the appropriate management skills and know how to utilize the rest of these players in the game. So RN, NP, PA, physician extenders, we have 3 of those in my office. They are very good at managing diabetes. I have a PA who goes to the hospital with me, and she comes back and says, I want to do this, this, and this for these patients. And I say, okay, sounds good. She's well trained. She's got the hang of it. Sometimes I say, I'd rather do it this way, but it's really a matter of style, not a matter of substance. Need a dietitian. Somebody tell you how to eat. The misunderstanding of what goes in your mouth and what comes out as blood sugar is tremendous if you don't have the appropriate education. Most of us, the great majority, have for breakfast 100% carbs, right? Orange juice, cereal, banana, and a cup of coffee with some milk and cream in it. Nothing but carbs in that breakfast. Nothing. And what does that do? Blood sugar goes up. High before lunch. So it really, people don't understand that it's not a muffin, it's not a donut, that it's not a carb. It's still a carb. Your body is much smarter than the women's magazines or what you see on the internet. It'll figure it out. Over here, diabetes educator. I run the Geckel Diabetes Center, so I have these folks and I have those folks in there with me, and they really are very